Good afternoon. I'm very impressed about my flag here, something a little uncommon for me. But yes, this is for me. Okay. Is the clicker. Okay. Okay. As I said before, it's for me a pleasure. Yesterday I've been flying for 14 hours from my office to be here in this city, and I would like to thank Banshi Sabu for inviting me and the organizing committee. As I said, I'm the president of Primary Care, an NPO, the only one NPO that is working, non-profit organization in primary care and diabetes in Europe. And I'm a medical doctor. I'm doing clinical work in Barcelona City in a primary care facility, okay? And I'm in a group practice where a total of 38 GPs, we are providing service to, in a big center we are visiting 50,000 citizens. We have a prevalence of diabetes, and my colleagues are referring me those complex diabetic patients to be considered to be attended in my clinic, okay? And I'm also visiting other kind of patients, just like normal patients in primary care. So the idea of this session is trying to move forward. These are my disclosures. Is trying to talk about a concept that is the idea of chronic complications of diabetes, micro and macrovascular complications. But at the moment we have in the field of diabetes, a lot of things coming. We have a lot of technology, we have a lot of challenges and barriers, and sometimes, although we are talking about, I said, mitochondria and things very specific and very scientific, we are not paying attention to a very, simple things. And the dialogue, diabetes education, if what we are learning in these sessions we are adopting in our clinical work, in our clinical field. Because adopting is very complex, it's not easy, okay? So the idea, and now we have a big tsunami of things. We have better access to data, and that data allow us to know what is our performance, how we are doing things ourselves, and try to learn from our gaps, from our areas of improvement. So I have to talk today about two aspects, as micro and macrovascular complications. I try to do a journey. Probably in my perspective, a lot of these things you already know. I try to provide some glimpse, some new concepts or ideas, okay? But let's start. I think that, of course, you know this classification is a classical one, and it talks about micro and macrovascular complications, and is related what is the vessel that is damaged due to the diabetes disease and the other comorbidities that are living together or at the same time of that person that is with diabetes disease. So, but it's important probably to keep in mind some, initial thoughts. We know that between 50 to 60% of persons living with diabetes have some cardiovascular disease. We know that around 40 to 44%, but that depends on how the disease is detected in your country, is also diagnosed of chronic kidney disease. Also, we know about that diabetic foot and non-traumatic amputations, the main cause is diabetes. We also know that around 16% of those over 65 years old with diabetes die from a stroke, and we know that in women it's more prevalent than in men, okay? And also we know that all those individuals that have diabetes over 40 years of age, they also present retinopathy. And so we know that diabetes as a disease is impacting in many places that are providing a lot of, disabling to the persons that we are visiting in our clinic. So it's very important to put the focus on that. One study I've been participating, and I think it's a good moment to share with you, is what a person with diabetes is looking for or waiting in the first contact, when the person is informed that he has diabetes. And has been performed a project, is called Time to Do More, that is published in Diabetes Research and Clinical Practice, where it is trying to compare what were the expectations of persons diagnosed and what were the expectations of the healthcare professionals, and trying to match. And I don't know what could be, what do you think, but the match, it was not really good. The expectations of patients that were diagnosed, it were about complications. And the expectations of the healthcare professionals, it were trying to insist on diet, physical activity, and maybe starting medications. But those things that worry most persons with living with diabetes are complications. So I think that is, and that it was a study not in Spain, it was done in many countries, Spain, Brazil, Japan, UK, States. So I think it was consistent everywhere. So sometimes healthcare professionals, we need to try to hear more what are those things that are worrying our persons in front of us, to understand how we can start a better dialogue and probably to involve the person in that process. Of course, probably the pathogenic explanation why hyperglycemia is provoking or is probably responsible for this damage at macrovascular places is well known. This has been studied, and there are many pathways that could explain that. Okay, and also there are different biomarkers that also are those ones that could explain in that pathways at the end that we are incrementing an oxidative stress and a pro-inflammatory status, and that could be the cause of providing damage on vessels at macrovascular level. So, but at the same time, we know that, and we know that in 1993, DDCT for the first time project why it has sense to treat diabetes. And I have been fortunate myself because I've been in the room when UKPDS was presented in 1998 in my city, and that also provoked a lot of surprise because before that date, we just trying to treat hyperglycemia, but we don't really have strong information about what were the consequences of being tight or not tight in metabolic control. And besides that, this is in DCCT in type 1 and in type 2, a lot of trials after just targeting blood glucose and also blood pressure and lipids were projecting the benefits of being probably following some targets. Also the STENO2 trial also emerged the relevance that probably not all the persons we have in front of us are equal in terms of risk, because it was demonstrated that those individuals with type 2, also with microalbuminuria, were at higher risk, and they have very important benefits in mortality if we target all the different risk factors in those patients. So I think it's important to keep that in mind, because that will open us the window and the reason why we have to try to be intensive or to share with our dialogue with patients why it's important we establish some targets, not just in metabolic control, also in other things, as a kind of a contract. And it's something I normally do. When my colleagues in my center, they are visiting type 2 diabetic patients and type 1, but sometimes they feel that they cannot move forward They feel frustrated because patients are not really reaching the target or because the patients are not adherent. Keep in mind, 40% of patients in Spain, 40%, 40, are not taking their medications for diabetes. So non-adherence is an issue. I don't know in your countries, but in my country is an issue. What we are doing for that? So talking about complications, it's opening a window about the reason why we have to treat this disease. Because patients are not having, majority of them, any complaint. They feel because the sugar, as they say, are not damaging them at that moment, is silent. The problem is when the sugar has a voice, because then probably the damage is not probably to be back. So let's start talking about retinopathy. I mean, we know about retinopathy. We know because retinopathy has been a very indexed complication in terms of diabetes. Before has been talking about the thresholds of diagnostics in type 2 and type 1, diabetes in general, and we know that that coming from epidemiological studies in retinopathy, okay? So I think that retinopathy is well identified. We know it's more prevalent in type 1 than in type 2, but that is due persons living with type 1 are living for many years and have more time to evolve with complications. So here we have the pathogeny of the disease. We know that there are different mechanisms, but I would like to pay the attention that also there are other risk factors. It's not just the glucose, it's also the high blood pressure, it's also that some hormones stress that can induce more risk to evolve with retinopathy. That's why when we have a person living with diabetes and is become pregnant, we have to pay special attention. That it means that probably we have to do more screening or more checks, okay? Because that is a risk, a situation that increases the risk of retinopathy. Also, it's also known that those ones already having some microvascular complications as chronic kidney disease or have kidney damage as albuminuria probably has a higher risk of having retinopathy. So, of course, kidney, and also there are some ethnicities that have more risk of evolving with retinopathy. How we are detecting retinopathy? And this is now having more changes, and probably I don't know how you are doing that, but we have moving from direct ophthalmoscopy in indirect, or probably referring the patient to an ophthalmologist. But now, and I don't know if here is also available, we start working with a portable retinographs. So a system like a mobile that you put in the eye, you pick a photo that goes to the cloud, and then you receive a report, and the system tells you when you have to do next check, okay? Because there's artificial intelligence also matching with the data of that person, telling you what is the risk of that patient to evolve retinopathy. And probably the idea of doing every 2 years, every 5 years is not anymore. Maybe depending on that kind of new algorithms is suggesting you to do it, I mean, lasting more time, or probably stratifying the risk of that persons that you're doing retinopathy. This is now a lot of emerging medtech innovation in that field. It's important also to understand, I don't know if you're doing reading of photographies of retina, but in my country, GPs are doing that in clinic. We are doing this technique in a facility, not in the eye clinic. We are doing in our primary care centers, and we are doing the reading also in primary care centers, doing shared care with the ophthalmologist. But of course, that depends how you are organizing healthcare. That is not in every place. I mean, the important is to provide the service. Another way is probably if we are sustainable how we are doing. But I mean, there are many ways to do it. But we are doing like this in my country. Another piece of another tool that has been very helpful lately is the optical coherence tomography. That one is trying to project data about the macula and the damage that in the macula is produced also in diabetes. So this is mainly used in eyes clinic, not in the primary care setting. So here we have a classification, and of course when we are detecting retinopathy, in some we are sharing that with the ophthalmologist, and that it goes immediately to the eye clinic. So we are just doing the screening, okay? Okay, when that is recommended, and in type 1 you see here projected, in type 2 a diagnosis, and then every 1-2 years, but as I said, artificial intelligence is going to introduce new changes on that domain as well, and pregnancy is inviting us to do it more frequent. There are also this evidence about the benefit of being tight of metabolic control of blood pressure, that it also brings benefits in terms of reducing retinopathy. So it's not just glucose control. So glucose control, blood pressure, stop smoking, photocoagulation if needed, and maybe other techniques that are more in the eyes clinic domain. The kidneys. Okay, the kidney has been a kind of reborn in the past years. Why? Because we have new compounds that now for the first time, from probably not first time, it's 9 years, when empagliflozin and the EMPA-REC trial was published and was presented in Stockholm ESD in 2015, is when we start having a new wisdom of we have compounds that change, probably could change the evolution of the diabetes, okay? And that has been a big change, and you know, because it has been projected before with the strategies in therapy. The etiopathogyny of diabetes you probably study in the medical school in the physiology, okay? Hyperfiltration, nephron stress, blah, blah, blah. You know that. I mean, it's not question of that. We have to go to the key points. But something that is not really well known, and probably for you could be a big surprise, is, of course, in just to keep simple, and that it will be maybe sticking in our minds, in the minds of the colleagues that probably you are advising, because majority of you here, you are endos or you are diabetologists, but you have a lot of GPs around you that you coach. And I think then they need to understand that when you are assessing the kidney, it's not just the creatinine, it's also the different estimation formulas you have. I mean, at least to use one. The ideal one could be CK-EPI, is the most, use it or, recommended, but also the damage, the albuminuria, okay? Why? Because that invites to also to put on the agenda of your colleagues the kidney. And it's not just to check the function, it's the function and the damage. And also invites the clinicians, your colleagues, and maybe yourselves as well, to stratify what's the risk. Because it's not the same that you have a person with microalbuminuria or the level of microalbuminuria, or you're observing a eGFR decline. This is very important because the risk of that person is much higher to another. So that makes that your attitude must be completely different in that individual compared to the other. So that is a sense. And because we have also tools to use on that persons. So it's normal, it's physiologic. We know that in the, with the aging, we're having a loss of the function, okay? But another story is the damage. And is the loss of proteins of albuminuria in the urine. And that's projecting damage in the nephron. And this is highly correlated with mortality. So we need, as we know that hypertrophy of left ventricular is also in the heart, is associated with complications, we know that albuminuria is a biomarker we need to keep in mind. That's why it's important to keep sense what we're doing, always. Because sometimes we don't provide the value to the actions we are doing. We are testing the albuminuria because that helps us to stratify the risk. And that helps to understand if we have to do something else to that patient. And that helps to us to explain the patient that is in a high-risk situation and our efforts must be different to another person. So, don't neglect the importance of all these things you are doing to incorporate in your communication and in your dialogue. So here we have in the next two slides, this and the next one, which ones are the non-modifiable risk factors and which ones are the modifiable ones. Of course, age is not modifiable, diabetes duration, genetic factors, ethnicity, etc. But those modifiable ones are very important to keep in mind in terms to know how we are going to work in terms to improve and to be better in terms of nephropathy. So dyslipidemia, hypertension, I mean also we know that sedentarism is highly correlated, obesity, metabolic syndrome, I mean also recurrent chronic infections are something that could be a cause of worsening in diabetes nephropathy. So what's saying KDIGO about that? KDIGO and the International Society of Nephrology has been working in terms to help all the scientific community to provide a simple way to operate, to understand chronic kidney disease, diabetic kidney disease. And this is a document we work together, my society, Primary Care Diabetes Europe, together with KDIGO and the International Society of Nephrology. That is a downloadable document that is trying to help any clinician in a very easy manner how to identify individuals, how to, what are the best aspects to keep in mind in terms to test that or to assess that kidney, okay, in terms of the function and the damage, as I said you before, and also how you have to diagnose chronic kidney disease. It's also mentioned that we know that now we are probably have a gap and we have an important area of improvement, mainly in terms of albuminuria. You know that the eGFR is a calculation. You can calculate. There are some labs that are projecting the value automatically, but there are others that you have to calculate by your own. But albuminuria is a parameter that is more complex to reach in many places. Also in Europe, in many countries, they are not allow clinicians in primary care to call for albuminuria. Probably it seems very strange, but that's real life. So how we are going to do a good assessment of a person if we don't have all the parameters that are going to help us for that? So this is an area of importance to keep in mind. Probably also to revisit in your countries, in your settings, if you know that probably is an area of improvement. Of course, why we need to test these two parameters? Because as also is projecting that, and this is very well known because it's a KDIGO color map that is helping the clinician to understand in what position you are, and then if you have to treat, and also maybe if you have to consult and you have to refer, okay? So that is very important in terms to put the person in that place and then react according to that. Of course, in terms of chronic kidney damage, I think we visit now what has been the last version published last December, January, of the standards of care of the ADA. And that ones are trying to project that when you have a person in that situation, that are the different scheme of therapeutics that are recommending. Besides metformin, and consider that metformin is contraindicated when you have eGFR below 30, you have also a strong advice to start using SGLT2 inhibitors, okay, without no specification of which one you have to use it. You have to use that mechanism. And also you have to also other tools to consider. Of course, on top of that, you also have other things to be considered if you are not reaching your targets. But of course, again, you need, and then if you see in that blue lines boxes, you see what is the diabetes pathway or roadmap that is recommending you to follow in case that you would like. So starting with SGLT2, and maybe if you are not under control, maybe consider the added value that GLP-1 receptor agonists also project and demonstrate that could be beneficial. So here is important that it's just not these compounds, but other things, and this is just a summary of what we already seen in that 2025 standards of care of the ADA. And of course, we have not to neglect that when you have a person with diabetes kidney disease, it's also other comorbidities. Before I mentioned retinopathy, okay? But it's also other things we have to keep in mind, because diabetes, when it's damaging the vascular tree, is not just targeting one place, it's targeting many. Let's move now to diabetes neuropathy, sorry. And diabetes neuropathy also is important, that is one of the microvascular complications. And here also is related to this reduced blood supply, and is producing ischemia in that vessels, and that invites for this damage and neuronal damage, and of course diabetic neuropathy. Here we have a classification in terms of neuropathy. Probably that one is more studied and have more impact, that is related to amputations. Amputations are related to peripheral neuropathy, and of course when you are living together with vasculopathy, peripheral artery disease, okay? But I think that here we have a summary of what we understand as a diabetes neuropathy, the autonomic neuropathy, the peripheral neuropathy, and I would like to be more focused on that one, okay? But probably it's important, and sometimes it's more rare, but sometimes we have patients that are affected with gastrointestinal neuropathy, and sometimes it's very difficult to manage that ones in terms of chronic diarrhea, other complaints, and this is a very complex situation, and it requires a specific advice and management, okay? But I think that, and of course, also this, when you are suspecting in patients that could have like cardiac autonomic neuropathy, that you need to be familiar with the different cardiograms. You can observe the different patterns. And that is also a high-risk individual, because can be affected at cardiological level of this neuropathy. Of course, something that is really not really well studied and known is about, and I see now, is sexual dysfunction. And it's something that could be bothering a lot of your patients in your clinic, okay? Many of them, and probably they feel like shy to share that in the dialogue, because they feel guilty, because they feel, I mean, in terms of their masculinity, etc. But sometimes if we open the discussion that a person living with that chronic disease and taking some specific medications, considering is a person living with diabetes and together with high blood pressure, they have a higher risk of having problems in that field, in the sexual dysfunction. Probably if you open that in a conversation, open conversation, that provide you surprises, and sometimes maybe more engagement of that person, what you are telling, not in that domain, in the other things, because you are empathizing with something they are feeling really as something they would like to share, but for them it's difficult to do it. They feel like in a kind of a bottleneck. So in terms of peripheral neuropathy, it's important to keep in mind that this could be affect up to the 50% of persons living with type 2 diabetes. I think is normally symmetric and polyneuropathy, but I think it's important that to detect that one and to do it well. But sometimes, I don't know you, but I see that we are doing things in automatical manner. I see in clinic, okay, I'm observing. Sometimes, and you know that is clinical inertia in management of diabetes. We know that we have persons with values of A1C over the target, and we are not reacting for years. Okay, we did a study in my country because we have access to all the database of diabetic persons, and we know that starting with a second medication, it takes more than 4 years with values of A1C over the target. So it's clear is a clinical inertia. So when we are calling for a specific parameter, we need to do it because we would like to do something else. If not, please, doing things automatically is horrible. In that case, I see sometimes how the food is explored, monofilament, and I see that maybe you are detecting a person with a high risk of diabetic foot, and that you are not activating any educational action. When you are detecting a person that is not reacting to monofilament due to you're suspecting diabetic neuropathy, what you need to do is to start doing some kind of advice in terms of education, kind of shoes, take care with your socks, how you are cleaning, how you are cutting your nails, etc., etc. Because if not, you can have the problem, and when you have the problem, then it's very difficult to change. So I think it's important how we do in the screening. We need to learn the techniques, and sometimes the techniques are not really well performed. I don't know if you are doing that technique or it's done from a personal in your center. But if you have the opportunity, please go and see how they are exploring diabetic foot. Because sometimes the technique they are doing to do it are also forcing some answers, and then what you are observing probably is not real of what is happening because you are inducing answers, how you are exploring or how you are trying to use the techniques to do the assessment of diabetes neuropathy. Here we have a classification, but it's very important one thing. We are not going to have amputation if we don't have two factors. One will be three factors. We need for sure neuropathy. Second, vascular problems, okay? And then could be also some kind of different problem in the, how we are on the articular problem in the joint, okay? Because, and then it means that when you are detecting neuropathy, your loss of sensation with the monofilament is a orange light that needs to invite you what's next. And that is, I think it's very important just to avoid that, and of course, if that person has some level of vascular disease, peripheral vascular disease. So what I'm saying that, because when you are detecting some level of what is projected here, low, moderate, or high, then that invites you to examination frequency. The examination frequency is just to revisit what's going on, to understand if the patient is following your advice, because then when something is happening, sometimes it's too late, okay? And as I said at the beginning, the most frequent cause of amputation, non-traumatic amputation, is diabetes. Okay, so it's important to manage the disease, and something that provokes a lot of discomfort is the painful neuropathy. So we know that some compounds, as pregabalin, gabapentin, duloxetine, and amitriptyline also in the past, but have a lot of side effects, could be medications to be considered to support and to help the patient suffering of painful neuropathy. Let's move now to the last part of my session, that will be the macrovascular one. I think it's here we have the ischemic heart disease, heart failure, and peripheral artery disease. Okay, and this is a definition, arteriosclerotic cardiovascular disease is defined of all of this list of things that is listed here. But it's important to know that that is the leading cause of mortality in diabetes. So, of course, arteriosclerotic cardiovascular disease is a really key aspect to keep in mind where you are managing persons living with diabetes. So, we know that approximately 1 of 3, so 33% of people with type 2 have any cardiovascular disease. And we know that 20 to 40% of people have heart failure. Heart failure is, again, another disease, another thing that have like a reactivation, okay? And also a lot of enthusiasm in other specialties, okay? Like cardiologists, that is very good because that allows us to detect more people, and that it means to provide solutions to that people that need solutions, okay, in terms of compounds. But we know that, at least in my perspective, heart failure, it was an area, a clinical problem that it was not really well diagnosed, not really well detected, okay? Of course, now we have better access to techniques. We have also the peptides. We also have echocardiography, the sonogram. We also have in some centers echoscopy, what they say echoscopy. They are doing sonogram, more simple one in the primary care setting to do an initial assessment. But of course, heart failure is an area that sometimes people were living with. It was not really well diagnosed, and that, of course, we were not offering a good approach. In terms of cardiovascular disease, I think it's very important, and this is an infogram coming from the last ADA standards of care, that we need to keep in mind that there's a basic thing, that is lifestyle modification and diabetes education. Of course, lifestyle modification is very complex. I mean, I don't know how many of you, when you have to start to take a medication for 7 days, you finish the medication. Imagine you have to change the things you are eating, your physical activity, etc., etc. So we need to empathize with that person in front of us, and of course, not the same recipe works for everybody. When we have a person over 75 years old, and we tell them, you need to do physical activity, what is the person doing after our clinic? Is going to do anything? Our advice is supportive, is helpful, or is not going to happen anything? I have the answer. It's not going to happen anything. You need to teach in the clinic what must be the exercise you recommend to that person, and probably to provide an example. Very simple. But you need to help them to twist the coin. Because if not, if you are just providing and doing very like the claiming, that is not going to change anything. It's the traditional approach. So lifestyle modification, and we need skills to provide advice, to provide good education that impacts, okay? Because we know that probably what we are doing is not working, okay? So we need to stress how we are delivering our education, okay, ourselves. Also, I incorporate that in that exercise. Of course, when we have discovered, and we have the person aligned. We need the person is willing what I have to do next. Look, something I did it for the first time, my colleagues, and this is a personal experience. I did, okay, before starting doing anything, I ask, why are you in my clinic? What is the reason you are here today? And they don't know. No, the doctor sent me here. They don't know what is the reason to be there in the clinic. So it's important, they need to be the owners, and then that it means they have the commitment, and that will be the critical factor for them to react and to be committed in the advice you are introducing them. Second thing I do, please, for the next day, 1 week or 2 weeks, please make photos with your mobile of the dishes you are doing. Make a photo and bring it to me, okay? And also take this paper and write what you're eating, not the quantity, what you're eating, like qualitative, okay? And bring it to me. That is the first test to know what is the patient commitment. Patient coming to the clinic, not bringing photos and not bringing the paper, I say, okay, I don't have information. What do you want from me to do next? I need that one. I provide a second chance, a second opportunity. But if the patient is not bringing me information, I said, I'm sorry, but I cannot help you, okay? Because, I mean, this is an example. You need to adapt. But the thing you would like here is to reach the commitment of that person to be the critical part of the change, okay? Of course, if we would like to improve glycemic control, blood pressure, lipid profile, all the cardiovascular agents, this is a teamwork. And the person that is driving the car or driving the bike is the person living with the problem, not ours. We just are coaching, okay? Okay, and this is aspects that, of course, are covered with the former slide. Aspects important to keep in mind in terms of screening that things, okay, is when is have any reason to screen coronary artery disease, routine screening is not recommended. It's not recommended if no is any symptom. When you have a symptom, when you have a breathless, then you suspect maybe heart failure. Then it's another thing. But screening without symptoms is not recommended. What's going on with heart failure? That's a different story. When you have some comorbidities, or maybe when you have some symptoms, then you have to react in a more organized manner. A peripheral artery disease. Every time the person came to their foot clinic or to the foot examination, you do the monofilament, you test, and you test the pulses. And you also ask about the potential of having any claudication walking. Okay, that is allow you to know something is going on. All your radars, your examination, all the communication. So that is very important in terms to start activating the screening. Of course, the screening to do something else. Okay, here are some more slides about how to address, and then in terms of management. And I think it's important to keep in mind that what are the solutions. That is an example, is again from the ADA 2025, so this last version, and how we have to understand the hypertension management on those persons, okay, and how we have to start. And I think, of course, it's clear when you have the values over 150/90, you can start with 2 compounds. When you are, and then, of course, and that are other parameters that are going to invite you to understand what must be the first component, the first medication you have to start using in that specific situation, because if the person has or not has albuminuria, etc., etc. Okay, this is following the algorithm. If you are not reaching the goals, you need to intensify the therapy. You don't have to delay. If you are doing that, you have to do it in a proactive manner. But that's your job, our task as a healthcare professional. The task of the patient is to provide you the blood pressure results. Your action must be to visit that results, comment that results with him or with her, and then react according to the results. Okay, and here, of course, is in terms of heart failure, we have to consider the use of the medications that probably you completely know. And of course, here is how we need to incorporate that new compounds that we know that are now, of course, in all the different guidelines and in the case of the heart failure. Of course, peripheral artery disease, and that is the last thing I'm going to talk about. I think it's awesome when a person came to your clinic, you need to start paying attention. I'm just going to explain you about a personal experience. My grandfather was type 2, my grandmother type 2, my father is type 2 diabetic, and my father is also 23 years hypertension, is well controlled for compounds, etc. And my father goes to a podiatric clinic, okay? And he went to the podiatric clinic, and after 4 or 5 days, my father said, I have a pain in the feet, and I have it's a little cold, and I go and see the feet. It was completely blue, has an ischemia. So, I mean, it's important, and my father was visited by a podologist 3 days before. What's going on? I mean, it's very important when you are, that was happening at least for 10 days. When you are in clinic and the person is let you know, I have something, like in that case we are talking about peripheral artery disease, I'm walking in the street, I force because I have problems in my legs and I don't know what's going on, that forced me to stop, and then I start walking again. And then when you examine the foot and you examine the leg, and the pulses, all of these have to invite you to see something is wrong. I need to activate the alarm, and then I have to think about hypotheses and probably being more proactive on what's going on. And we have a test. We have the ankle brachial index, okay? We are doing the ankle brachial index, But then again, we understand the results, we are reacting according to the results. Is results interpretation inertia? Please, if we are in that step that we already do a test, as we are doing kidney assessment, as we are doing A1C, and you are doing anchoral brachial index, react according to the results. And then, if the person is smoking and have high blood pressure, have other conditions, try to be tight with these factors, okay? So, and this is my last slide. And this slide try to see, okay, maybe probably the idea of macrovascular complications need to be more open, okay? Because there are other things we know they are living, other comorbidities. We know about the paper, the role of the liver. We know for many years. We know about, and now we know new compounds are going to come and to do a blossom of the liver in terms of the management of diabetes, as we have at the metabolic syndrome in late 90s when we have the glitazones, we have, or the postprandial wave. Okay, do you remember? And it was a lot of fashion about taking postprandial, okay? Because we have acarbose, we have repaglinide, we have other compounds. But don't feel like this is something that allows us to invite and to revisit the pathophysiology of the disease. And sometimes all of these complications are interconnected. And it's not just niche in one specific disease as diabetes, have other important comorbidities, and we have to make this important diagnosis that allow us to see what are the aspects we have to keep in mind for a good management of that person. So thank you very much.